Καλησπέρα και από μένα. Θα σας παρουσιάσω την πρώτη ομιλήτριά μας, η οποία είναι η Ουρανία Πρεβέντζα. Θα συνεχίσω λίγο στα αγγλικά, η ομιλήτρια θα μιλήσει στα αγγλικά. Dr. Prevendza is the professor of surgery in the division of cardiothoracic surgery at Baylor College of Medicine. She has now, we met her at Texas Heart Institute during our training, and now she took the position of chief of the division of the cardiothoracic surgery and co-director of heart and vascular service line at the University of Virginia. Her academic work is internationally well known in complex and cardiac aortic surgery, and especially in the cardiothoracic and the vascular aortic techniques. Rania, it's your turn. Thank you.
Hi, can everybody hear me? Μ' ακούτε?
Ναι, είναι πολύ καλά.
Οκ, ευχαριστώ πολύ. Καταρχήν θέλω να ευχαριστήσω τον κύριο Κοφίδη, την κυρία Βασιλιάδου, Αθηνά Ράμου και τον κύριο Κοτούλα και όλο το Προεδρείο για αυτή την τεράστια τιμή. Η ομιλία θα είναι στα αγγλικά και ευχαριστώ πάρα πολύ για το χρόνο σας σήμερα πρωί σε εμάς, απόγευμα σε εσάς. So with not further ado, my talk is for the guidelines. And these guidelines was from the collaboration from the American College of Cardiology and the American Heart Association, and was published last November. This is my disclosures. I had the privilege and the honor to actually represent the cardiothoracic community in the US as a vice chair for the writing committee, along with Dr. Eiselbacher from Mass General, that he was a chair and he was a cardiologist, and Jim Black, that he was a vascular representative. And you can see here the people in red were all the cardiac surgeons involved when we developed these guidelines. And the committee had anesthesiologists, vascular surgeons, cardiac surgeons, as well as cardiologists. And the important thing here actually was that these guidelines really developed in collaboration and endorsed by the American Association for Thoracic Surgery, American College of Cardiology, Cardiovascular Anesthesia, Society for Cardiovascular Angiography and Interventions, Society for Vascular Surgery, and Society of Thoracic Surgeons. So I'm going to talk a few things regarding the take-home messages and what is important for the surgeons, all the cardiovascular surgeons who are actually dealing with aortic disease, and what is the latest ECMO guidelines. So one thing that was really very much endorsed was that one is the multidisciplinary aortic team, how important it is, and of course the threshold for intervention. So if we talk about sporadic aortic root and ascending aortic aneurysms, the threshold was lower from 5.5 to 5 in selected ECMO patients, and even lower in patients with heritable thoracic aortic aneurysms. Another take-home message was that on the surgical ECMO thresholds, we incorporated the patient's body surface area when we talk about ECMO 5 centimeters or 5.5, and also we incorporated the height or the cross-sectional ECMO area. And that was something that was really important for the entire committee to make sure that this is definitely, we emphasize that. And we, especially for patients who are outside from the 1 or 2 standard definition, then these are the patients that we use the aortic index, that was the diameter divided by the body surface area, the PSA. And we used also the height index, diameter divided by the patient height or the cross-sectional area. Another take-home message is that If there is rapid aortic root growth, this is an indication for intervention. And how that was defined by 0.5 growth greater than 0.5 centimeter in a year, or 0.3 centimeter per year in 2 consecutive years for those with sporadic aneurysms, and 0.3 centimeters in a year for those with irritable thoracic aortic disease. Another take-home message was that with regards to the valve-sparing procedures, patients that they have aortic root aneurysms, we thought that, and the evidence showed that aortic valve-sparing procedure is reasonable if the valve is suitable for repair, and when performed, and we are going to hear this multiple times, by experienced surgeons in a multidisciplinary aortic team. Again, the multidisciplinary aortic team was one of the major things that was really introduced, and we really emphasized on these guidelines. Patients with acute type A aortic dissections, if they're clinically stable, this is also the other thing that we added on the guidelines, is that these patients should be transferred to a higher volume aortic center, and the operative repair should at least entail an open distal anastomosis, meaning without the cross clamp. In patients that they have aneurysms or of the ascending aorta or the root, or those with the dissection, we recommended screening of first-degree relatives with aortic imaging. And just again, a few, from the specific regarding to the ascending aorta in the root, we can see that it's class 1 recommendation if the patient is actually symptomatic. If the diameter is more than 5.5, again, gets to class 1. And then if the, you can see actually on the yellow here, if you can see my cursor, if the diameter is more than 5, the surgery is reasonable, and this is actually class 2A indication. And again, if somebody is replacing the aortic valve and the ascending aorta is more than 4.5, then this is a 2A recommendation, meaning that the ascending, if you replace the aortic valve, then ascending aortic replacement, if it is more than 4.5, is reasonable, given that it is performed by experienced surgeon in a multidisciplinary aortic team. This is what the MAT means, multidisciplinary aortic team. And then if a patient is undergoing aortic surgery, cardiac surgery for any other reason, meaning potentially mitral valve or a CAB or coronary artery bypass, then if the ascending aorta is equal to 5 or higher, then maybe it's reasonable again to be replaced. And of course, we have here the aortic size index, as you can see, and size index and height index. This is really what changed on these guidelines, that with the diameter from, of course, if it is more than 5.5, that's class 1. If it is 5, then this is what we actually place as a 2A. Again, surgery is reasonable, experienced surgeon, multidisciplinary aortic team. This is an ongoing actually trial. This is Titan. We don't really know what happened with the patients a lot of times between 5 to 5.5. And currently there is this Titan study from Canada where they randomize patients. And down the line, we hope that this trial will give us some answers with regards to what is happening in these patients between 5 to 5.5. We don't need to go into a lot of details here, but you can see what is highlighted in red. What we do in surgery is a simple aneurysm resection and replacement with interposition graft. If the patient undergone valve surgery and replacement, then a separate valve and ascending graft is recommended. Regarding to the aortic root, everything depends if the valve is suitable to valve sparing, then valve sparing again is reasonable when performed by experienced surgeon in a multidisciplinary aortic team, again as a 2A recommendation. Regarding the bicuspid aortic valve, class 1, if the aneurysm is more than 5.5, and 2A, if it is a cross-sectional route or the area to hide is more than 10. Again, experienced surgeons in a multidisciplinary aortic team as a 2A recommendation. And then you can see here, if somebody has a bicuspid aortic valve, if the diameter is between 5 to 5.4, and there is an additional risk for dissection, then again, surgery is reasonable as a 2A indication. And what we mean about risk factors for dissection is a family history, aortic growth, correctation, and the phenotype. If somebody undergoing surgical aortic valve repair or replacement and has a bicuspid aortic valve, then if the ascending aorta is more than 4.5, again, is reasonable to be replaced, and this is a 2A recommendation. As a 2B, that means that maybe is reasonable, again, when performed by experienced surgeon in multidisciplinary team, is if somebody has a bicuspid aortic valve, if the diameter of the ascending aorta is 5 to 5.5 to 5.4, but there's no any other risk factor, as we actually saw before, and the patient is low risk, then surgery may be reasonable. With regards to the IMH is intramural hematoma. If, of course, somebody has complicated acute type A or type B kind of intramural hematoma, agent repair is recommended. This is some of the future for the complicated, meaning if there is malperfusion, hematoma, effusion, refractory pain, or rupture. Again, complicated repair is recommended. If it is a complicated, and we can see here for the type A distribution, similar to type 1 aortic dissection, then open surgical repair again is recommended. And but if the patient has uncomplicated, that meaning with not any of the features that we showed, then maybe surgery and medical management may be considered. This is some of the high-risk imaging. This has to do with the aortic diameter, the hematoma thickness. This is a lot of details here, and of course this document, I have to say, that was like 200-300-page document. But one of the good things that's on this document is that this is actually a living document, means that this is going to be updated every few years. And in the beginning of this document, there is all these take-home messages that actually I mentioned in the beginning and of the talk. A few things with regards to the aortic arch. If the patient, of course, is symptomatic, makes sense. This is class 1 indication, open surgical repair. If the arch is more than 5.5 and the patient is low risk, then open repair is reasonable, 2A. Of course, this here, that's why I said it's a living document, because a lot of these things didn't even appear in the prior guidelines. That was in 2010. But again, given that this is going to be a living document, that is going to change as we go in the next few years. Potentially, maybe some of these recommendations will change. We don't know. Depends the evidence. But currently, if the patient is asymptomatic, if the aneurysm is 5.5 and is a high risk, then hybrid or an endo procedure, as Dr. Kofidis mentioned in the beginning, maybe is reasonable, and this is ECMO 2B. Regarding the thoracoabdominal, the classic is if it is anybody that is symptomatic or rupture, open repair is a class 1. When is a repair? If it is 6 centimeters. again, and if it is intact, of course. And regarding the patients that they have some genetic Egmont syndrome, open repair is recommended over an endovascular Egmont repair. And I'm going to finish by that the key takeaway messages is that the goal to prophylactic, usually we don't do anything prophylactically. We do it because there is a reason for. And the goal for any prophylactic Egmont repair is really to prevent life-threatening complications from acute events such as rupture or dissection or death. And this goal is best achieved when the risk of any future adverse aortic events is greater than the expected surgical mortality. And this is where, of course, the surgeons as well as the institution's experience is extremely important. And this is some of the things that we have identified as the group, and when we have the guidelines, future directions, as well as the existing Egmont gaps. We do recognize that biomarker studies will be something that will help us in the future. There's a lot of genetic Egmont testing, and we also understood that a lot of environmental factors and lifestyle habits that may contribute to aortic aneurysm formation, and this is something we have to study more. And of course, we have genetic and non-genetic Egmont factors that, of course, will help us down the line to improve our risk stratifications, risk stratification in these patients. There is some other gaps in future directions. We do understand that there is difference between Egmont male versus Egmont female Egmont patients. We do need also to improve the quality of life, and there's not really a lot of studies talking about quality of life in these patients. We don't really know a lot of things with regards to the rehab as well as individual exercise programs for these patients pre-op, before surgery, as well as after the surgery. And of course, we have a lot of social demographic disparities that pose challenges for these Egmont patients. Again, I would like to thank Dr. Kotoulas, Vasiliadou, Athena Ramou, Dr. Kofidis, and the rest of the panel and the presidents for this kind invitation. I know Vicky as well as Athena for many years since I was when I was in Houston, and they've been excellent in their work. And I think you have to be you're very lucky to have both of them there. And I'm so glad that both of them are back in Greece to offer the services there. Glad to answer any questions. Thank you. Σας ευχαριστώ πάρα πολύ.
Thank you, Dr. Prevendza, for your excellent presentation and your new guidelines. We would like to have a talk from Ms. Mirli Anna. A comment, please.
Hello, and thank you so much for this concise presentation and the work that has